Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same. Hello, everyone, and welcome to a new season of the Sleep is My Waking Passion podcast. You know who I am. I'm your host, Dr. Alison Kole, and today I'm joined by Jill McGarry, who is a clinical psychologist hailing from the UK. Welcome, Jill. It's so wonderful to have you.
Thank you very much. Thank you so much for inviting me. Yeah, we can share lots across the water, can't we? No water can get in the way of important information.
Exactly. And I love the fact that I can have these international conversations. And I'm learning so much from people who just have different diverse backgrounds and experiences. So today, for those who are listening, we're really going to be focused on neurodiversity, specifically autism and ADHD, though I'm going to let Jill take it wherever she wants to take that conversation, and how sleep can be impacted when you are someone who's of a neurodiverse sort of background, because there's some unique issues that happen with sleep there. So we want to go over that, and also some tools that might help either yourself if you're neurodivergent or a loved one that you are working with who has who's neurodivergent and really may be struggling with their sleep, and how we can optimize that. So Jill is a consultant clinical psychologist. She has nearly 30 years of NHS experience in psychological support for people with mental health issues. So the NHS is the National Health Service, and it's basically the healthcare system in the UK upon which the majority of people get their healthcare. At least Dr. Google told me that. Is that fair?
Yes, that's definitely it. You know, some people have private insurance as well, but not everybody. So, yeah, most people get their care via the NHS. And it's pretty expensive. Okay. We have sleep clinics within it. Yeah. So initially her work with the NHS was within the brain injury realm. And then now for the past 20 years, her main focus has been in learning disability and autism services. And she's most recently extended her services to incorporate the perinatal period. So we're talking moms with babies who are under 2, who may be struggling with some mental health issues. Throughout her work, Jill has built a wealth of knowledge and experience, which has led her to be passionate about the benefits of improving people's sleep. I love it. Recently, this was consolidated with attending courses. So she's been in 2 prestigious sleep teams, Oxford University's SCNI and the Sleep Unlimited, as well as the behavioral sleep medicine seminars from Arizona, which I'm very familiar with. I've even listened to a few of them. I think that's with Michael Gradner, if I'm not mistaken, because he's a big proponent of providing that education, which is wonderful. I'm sorry? And we're probably both listening in at the same time to those seminars, perhaps.
We probably are, and they're terrific. And it's so wonderful that there can be access to it. Sometimes I have to sneak them in because they'll be at a time during work, and I'll be like, well, I have some mental break. I have a little bit of bandwidth. Let me take a listen. But my goodness, so good, so good. So currently, Jill runs a part-time private practice for improving sleep, as well as working 3 days a week in the psychology department at Manchester's NHS Sleep Service. Over the past year, Jill has carried out numerous sleep awareness courses for well-being teams, private organizations, LD psychiatrists. What does LD stand for?
People with learning disabilities. So not just people with
and then what does ASD stand for?
Autism.
Okay, so
autism spectrum disorder.
So she has autism spectrum. Got it. Okay. I just want to make sure I understand all the acronyms. So over the past year, Jill has carried out numerous sleep awareness services and courses for well-being teams, private organizations, learning and disability psychiatrists, and psychology services, as well as co-facilitating a national conference on sleep, autism spectrum, and learning disabilities. Last year, she ran the sleep clinic for the National Autism Show. Okay, there was a typo here. All right, so last year, she ran the sleep clinic for the National Autism Show at the 3 large conference centers in England, as well as a webinar on autism sleep
And she was also on a podcast for Zencast on ADHD and sleep. So, by the way, I will reiterate this at the end of the show, and I'm going to pause for a second and let everyone listening know that she does offer a 15-minute free consultation on phone, and she holds a virtual clinic on Tuesday to Thursday, as well as well-being workshops that focus on sleep. Her website is www.sleepbetterdoctor.co.uk. All of that's going to be in my bio. All right, Jill, without further ado, I am so excited to have you. I think what I wanted to start out with is let's level set. When we speak about neurodiversity, what exactly are we referring to? Can you enlighten people in that respect?
So there are a group of people that have autism, and some people that have ADHD, and some people that have dyslexia or dyscalculia or dyspraxia. So autism is a condition that we often call as a triad. That means that they have problems in three areas. One with flexible thinking or problem solving or imagination, it's sometimes known as, problems with social communication and problems with relationships. But often they have lots of sensory needs as well, which means that sleeping is really hard for them. The next group of people is people with ADHD, so attention deficit hyperactivity disorder. And they sometimes cross over. About a third of people with one condition has the other. But actually, there's another overlap. So it's a bit like the Olympic Games. It's like a shorter version of the rings, just 3 of them instead of 6. But there's only 3. So the other one is dyslexia and dyscalculia. And quite often, people can have all 3 of those. So they sit right in the middle of those crossover rings. But sometimes they might just have dyslexia, dyscalculia. So a best way to put all those conditions together is to call it neurodivergent rather than to go into too many different acronyms. It can be really challenging having any of those conditions, but to have all 3 or 2 of them is tough.
And I just wanted to, this is a little bit of a segue, but I would be remiss if I didn't say this. Just this past week, it's so funny how things happen. Like we had pre-planned this, we had scheduled this, and then here in the United States, we have someone who's been very vocal about saying absolutely ridiculous things about people with autism. And you may have heard of RFK Jr. Is who I'm referring to. He has said things about how autistic people really can't have meaningful relationships. This has been all over TikTok, on the internet. It's been crazy. That, they can't hold jobs, that there's such a spectrum here. And I am probably not going to be able to wax as intellectual as some of my colleagues who actually have children in this realm. But, I would say that my youngest fits into that category. She does have ADHD type components, and we've had her assessed for autism. Unfortunately, there's no evidence of that for her. That being said, if you have a neurodivergent condition, this does not mean that there's something wrong with you. You're just different. So I wanted to level set because there's been some negative talk regarding neurodivergent people. And I wanted to pause and reflect on that because of what's going on in our country. And I think it needs to be stated that we are here to try to help improve sleep and help neurodivergent folks kind of grow and excel and live their best life, really. I don't think we should be trying to assume that people should be held back as a result of having that quote label.
I totally agree. And actually, when we look at history and who were the best inventors and who actually propelled the human race to be more than cavemen and cavewomen, they will have been all the people with autism and ADHD and dyslexia, because they weren't interested in the mundane stuff. They have a better sense of how to get things sorted. Some people might get hugely hooked into social relationships and social communication. However, if you've got a broader skill set, as somebody with autism would have, or ADHD, then actually you can create things that can't even be imagined by somebody that's so super focused on social interaction. So I think it's undermining. But also, to say that they can't have relationships is quite the opposite. It used to be said for people with autism that they don't have much emotion, and that is not the case. Often now the data and research is coming through that actually they feel things more. And because they feel other people's pain more, it might seem like they're cutting off because they need a little bit of distance just to be able to process somebody else's, because they'll have their own emotions over a situation as well. So it can come across in a certain way that isn't the case at all. And it's very shallow, isn't it, to think of those horrendous ideas that they can't have jobs. I don't think you've got a lady called Temple Grandin in Texas that is one of our best experts on autism. She's done incredible things. And she talks about the best way to get a job when you're autistic is to go through the side door, not through the front door, because they're not, quite often people with autism might not be great at being interviewed. But hey, if they were able to have the contacts and they're showing their skills and their abilities through the back door and through connections, then they can be the best person for many different companies to take on some of the roles.
Yes. Such an important off-topic thing to sleep, but we had to say it. And thank you for participating in that dialogue, because it's really distressing sometimes when you are like, seriously, I thought we were moving away from this and we've been like pulled back to this old school way of thinking. Jill, can you describe for my audience what types of sleep issues that you commonly encounter in folks who are neurodiverse?
Okay. The most common problem is getting off to sleep. And it's not the usual kind of getting off to sleep that might take you, instead of the average, there's never an average, is there? It's got a range to it, and 15 minutes. For the ordinary person, it might take them an extra half an hour because they've still got their mind whirring, they're still thinking about things. But quite often for people with neurodivergency, especially autism, it can take them up to 4 hours to go to sleep. That's not uncommon in my clinic. And you can imagine that people lose whole sections of their life. I've just finished working with a young guy who's only 17, and it was taking him, we worked out 4 hours. And when we managed to fix it, it was only taking him 15 minutes. And he was like, I've got time to socialize now. I don't have to go to bed early to be able to get my right amount of sleep. Oh my God, I can go to the gym. I can chat and watch the same programs as others. It can open a whole world for people. And he was really good because he prioritized his sleep, whereas other people would go, it'll take me 4 hours to go to sleep, so perhaps I'll only get 4 hours of sleep because I still want to do those other things. But only getting 4 hours of sleep, that other side of it, for others that do that, it's not a great game. You're nowhere near functioning at your best when you've only got 4 hours sleep. So, that onset is probably the biggest, and why you mentioned right at the very beginning melatonin. It's a big part of that picture. And perhaps we want to talk about circadian rhythms a little, about why that happens. But yeah, for 80% of people with autism, the research in the NHS is showing us in the UK that they have problems with that getting off to sleep, which we call sleep onset. And therefore, in the UK, we have a strand of our National Health Service called NICE. So NICE stands for National Institute for Clinical Excellence. So I think it might be a bit like your, I don't know, body that agrees what medicine can be used. Is it called? I can't remember what your body might do.
Well, we've like the FDA, the Food and Drug Administration. I don't know if that's the same analogy.
No, it's not. But... No. So our doctors in GP practices, general practitioners, and our doctors in hospitals can only give medication that has been agreed by the NICE guidance. Or therapists can only provide therapy that's been found by the research and agreed by NICE to be offered to the population.
I think what you're referring to, we have Medicare makes a lot of the rules for a certain group of people that are getting sort of a governmental level of, this is your now Medicare insurance. You've now aged or met the criteria to now have Medicare be your healthcare insurance. And then they will have certain medications that are on formulary, and that may change depending on the circumstances, or even treatments, really. And then you have private insurers who then have their own sort of rules and sets for people who are not Medicare and just have private insurance. And it depends, because you have one private insurer who says, yes, you can have this medication. You have another who doesn't. And the frustrating part is if the patient has been doing well on one medication, one of the things we see is that they're like, well, that's just not formulary, so they're going to have to pay X number of dollars out of pocket. And you're just like, Can I just treat them because I know what's right for them? I mean, can I just, I don't know, this whole like med school residency fellowship thing that I spent over a decade doing, can I just like practice medicine? Yeah. So
and it
again, a tangent on what's happening in my country, but
it's not too far off what's happening in England because, you know, I will often speak to parents or adults with autism and say, you know, nice guidance has told us you have the right to have melatonin because the research has showed us for your sleep onset problem, it can make a big difference. For some people that don't want to take medication, we can find other ways to do it. And we could talk a little bit about that if we like. But, you know, for them, they sometimes go back to their GP and tell their GP, oh, I've been told I can have medication, melatonin. And the GP goes, never heard of it. I've never heard of that guidance. So I literally have to tell them the number of the guidance, 16, I want the 196. And so they can actually take the document to the GP to say to them, I have a legal right to have this because it's written in your guidance. So do you know, it might, that might
that's a different kind of torture in the healthcare system. I mean, it's like not that, you're right. It isn't that different. And it's a different kind of torture that like, it's like hair, but it gets to a universal theme, which is the reason I love doing this show, which is it is imperative that folks who are listening, this is a message for the general public that please be proactive in continuing to nudge and move the folks that take care of you, that give you those prescriptions, please nudge them in the right direction. You have to be your own best advocate. And I used to have sort of an idea that, oh, well, it's bad that you have to be your own advocate, but it's like the necessary evil. You have to, you know, kind of be involved with your own healthcare. I have a different attitude. I don't judge it anymore. I just look at it as being common sense. There's so much information, so many restrictions upon which we as providers can even work, and it morphs how you approach life, especially if you're feeling very overwhelmed. You have a very heavy patient load, which is the classic insurance model. See more people so that you can keep your lights on at the end of the day. And it gets to the point where the very provider who wants to take the time to help you, who wants to take the time to know what the latest guidelines are, simply do not have the bandwidth. I mean, my guess is it's going to be similar to what I experienced when I was in full-time clinical practice, which is essentially, I'm like, learn about a new medication. I'm glad I had a chance to go to the bathroom today. You know, it's like, or shove a bite of sandwich into my mouth in between patients. I kind of feel like that's where my reality has been. And I know I'm not alone. So I love that we're talking about needing the patient to really sit there and say, here is the document. This is what it needs to happen, because we need to help our colleagues out. We do. They can't know everything. And it's what I'm saying is these are smart people and it's not always their fault. It's a systemic problem. And we have to work around that systemic problem. And it sounds like it's different. It looks different, but it's a systemic problem no matter where you are. But the UK is still struggling, just like folks here in the United States as well.
And I think that's right. I think we have to take responsibility for our own health. Nobody else is going to do that. Nobody's going to prioritize you. So, you know, you have got to be savvy. But some of the systems are really complicated, aren't they? Some of the language you have to learn. To also have a condition that means you don't sleep well, means you find it hard to take on board new information. So it's really hard. And therefore, having some people like you and me around that can give you some shortcuts to cut through it all, to get the answers that might be needed by us listening really carefully is vital. I think for us in the UK, because we have to follow nice guidance, or we don't when it's private healthcare to the same degree, we can go off script a little bit more, is for nice guidance on autism and sleep onset problems, like getting off to sleep problem. They only prescribe melatonin from the ages of 3 to 19. So does an autistic brain change at the age of 19? No. You know, when you have your 19th birthday, melatonin doesn't just start working more efficiently, or your brain can't just synthesize it effectively when you turn 19. And the only reason they put 19 on it is because the research isn't there yet. So I get it makes complete sense. It sounds scientific sense to not prescribe something until you've got the research, but it just means we have to do more research. We have to get better at doing that end.
I have a question for you. In terms of the type of melatonin, is it truly a prescription that you are providing? And does that mean that the prescription is not an over-the-counter supplement like what's available in the United States, but really created in a lab? And so the dosing is correct in England?
So I have some clients that don't want to take medication, and I have some clients that are absolutely desperate to take medication, but they're over the age of 19. So the only way they can get it, because it is a natural substance, it's not like synthetically made. Melatonin you can get from Amazon. The problem is when you buy it from places like Amazon, it usually comes in 10 milligram amount, and that is too much. That actually has the opposite effect to what you need. You need it to be 3, maximum 4 for it to be at its most effective. It starts affecting your sleep in the wrong direction if you take too much. So, but I often work with people that don't even want to take the medication. They want to do things naturally. And what we need to do when we're doing that work is to help educate people to why they need melatonin. What is it that's happening to their sleep that means they need that medication or that extra nutrient? So I will teach them about the fact that our eyes synthesize melatonin for our brain and for our sleep from the daylight, and that we when you've got autism, you need more daylight. So the average person can make enough melatonin to get us off to sleep with 20 minutes daylight. However, somebody with autism might need longer. And for each person with autism, it's a different length of time. I mean, some people, we've looked at it and we've been able to narrow it down to 2 hours. For one gentleman I'm just in the middle of working with, he's just been to Las Vegas on holiday. And while he was away, he got enough sleep and he got off to sleep within 15 minutes. So we worked out how many hours have you been outside? And it was between 4 and 5 hours. So he needs 4 or 5 hours of daylight to create enough melatonin.
This is fascinating. So I've spoken about melatonin with Beth Ann Mallow. I've spoken to Mikey Goldman, who has ADHD. So guys, you can check out those other episodes. Mm-hmm. But this is the first I've heard that really what it comes down to is if you want a natural prescription, use sunlight to your advantage. And then that longer amounts of sunlight could be different. Wow. Yeah. Is this from the time that you are waking up, for example, that morning light that works for most of us to entrain our circadian rhythm? Is it the same idea, or are there points in time? Do you notice a difference between getting maybe a longer length of morning light, but then also mid-afternoon, which we know sometimes helps to entrain the circadian rhythm in a non-neurodivergent person?
Well, it's all new science, to tell you the truth, Alison. I wouldn't like to say for sure, but what I do see in clinic, it's just the amount. I know that sort of clinic-wise as well, the more you get in the morning, the better as well. You know, it's got a stronger circadian influence by having that light in the morning. For some people, you know, they really want to super use the light to its best ability. So they try and watch sunset as well, wherever they can, to help those indicators, those markers of the day. But yeah, it can be any time in the day. But sometimes, you know, for one gentleman I worked with, he was working in a factory. So how is he going to get that daylight? You know, he can walk to work, which is what he's decided to do to get as much daylight as possible. And he walked home from work. So that gave him a lot more daylight, but nothing like the 4 hours that he needed. And so we had to use a light box, or a lux lamp, as we'd call it. So I don't know if you've had conversations on here, Alison, about those. But they can be part of that natural. I know it doesn't sound natural because it's an artificial light, but it's a light that's been created with that very need to make melatonin in mind. And they use them in, I don't know whether it's been some places in America, actually, in the Scandic countries, in Europe, and they don't get much daylight in the winter. And so they do suffer from sleep onset problems, and they do suffer from seasonal affective disorder. So lots of families have a shower in their conservatory room, not a light shower, not a water shower, a light shower. So they'd have a lux lamp above them all. So they all eat breakfast, having a bathe in that light that is beneficial, that they won't get naturally. So in some countries, it's become part of their way of life. And I love sharing the fact that
I didn't even know those existed.
Mm-hmm.
That idea is terrific, especially if, let's say, you've got to do a job where you are kind of at least here in this country, we're often very sleep deprived. We may be running from job to job. And if you're trying to maximize what you can do that.
Yeah.
Jill, I'm going to show you something I have taught. Literally, the guys from IO, can we start collaborating, guys, out there? Hopefully you're seeing this podcast because I've talked so much about their product. But this little guy, you can see there's like a little light. You wear it on your eyes like that. And this thing is really neat because it'll go on, it's a little different. And I think maybe what you're talking about may be more effective just because you can have it for longer, especially if it's going to be overhead.
Yeah.
But something like this, it goes on for about 20 minutes or so. And you can walk around with it, make breakfast, do whatever you got to do. So you can kind of multitask wearing something like that. But the bottom line is use those tools. Wow. What other sleep issues do you sometimes have, and what are your other tricks? Because you mentioned a lot of folks don't want to necessarily go on melatonin. What else can they do?
So if it's a sleep onset problem, the other thing is to eat food that's got melatonin in that could be really helpful, but to anchor your day, to always get up at the same time of the day, which fits in neatly with the other problem that lots of people have, and that's staying asleep or getting asleep and staying asleep. So that traditional sleep insomnia issue, when you just can't get enough of sleep, no matter how much time you spend in bed. And in fact, the longer you spend in bed, the worse it gets. So I would always use techniques of cognitive behavior therapy for insomnia then. And that is common for people with ADHD and for people with autism and dyslexia, but particularly ADHD. That idea that your brain is always working and it's hard to calm it down to be able to, what I would call it, getting off to sleep is like your plane landing, and it needs a nice soft landing like a plane. And we're not helicoptered. We can't just plop out of the sky. And so I spend some of my clinics sometimes talking about all this social media stuff, that we can hold a phone in our bed and still chat to people and still get YouTube and TikToks. So I quite often team up with a couple of colleagues that do digital culture, how to help us not to always be on those digital gadgets, so that can help us sleep, because we don't want to be.
And I had heard that neurodivergent folks often they may use social media or their phone or just some sort of electronic device in a way that's almost like they're trying to soothe themselves. So they use it almost a little differently than perhaps someone who's more, quote, neurotypical. And I was curious about what some of the guidance is as to how to break that, because I assume it probably applies to everyone, but it may be even more effective in that specific, niche of patients.
Yeah. So what I would always say is find out if going on your gadget or doing gaming has a calming effect on your body, helps you do that soft landing, then it can be a good thing to do. If it doesn't, if it heightens your anxiety or heightens your excitement and gets you all kind of adrenaline rushing, cortisol playing up, then you're not going to be able to calm and go to sleep and stay asleep. So the more we can get people to think about what gadgets they go on at night. The other thing that's often different between neurotypical is that we say with sleep hygiene to make your bedroom as empty as possible, and to remove things so that your bedroom is only for sleeping and having sex. But you can do that anywhere else anyway. But your bedroom is there for that, and therefore you should remove everything else from it. But actually, for people with autism and some other neurodivergent aspects as well, people are saying that actually, and the research is coming through when we've done service user forums, that actually they need their nest around them. So they call it nesting. So quite often people will have the things that have a special interest or things that make them feel attached and soothed around them, whether it be soothing as in hugging something or just having the nest literally around their bed. For one young gentleman, he was really into the planets and his brother slept on the bunk above him. So we put a poster of all the planets on the bottom of the top bunk so he could see it when he was asleep. And that helped him have his nest as well as a few objects around him. So the idea of clearing it all out actually makes people feel more anxious. So really chatting to your kid or thinking about yourself, what is it that would work for you as an individual? Because for people with that three triad part, 3 aspects, all the Venn diagram circles, you're going to be thinking about sensory needs as well. So some people with autism can have really heightened sense of smell. So you might be thinking, what's in the room that might be distracting or not comforting? Can we put some other smells in there? Because our sense of smell is almost primeval, and it's the one that switches off last at night. So if we can put some smells in there that also help relax you and calm you, they can be really useful. But it might also be about, we don't just have 5 senses. We have 8, actually. I was going to say 7, but we now know it's 8. So it's the usual 4, plus proprioception, so knowing where your body parts are, plus vestibular, so having a sense of balance, and plus interoception. So if you can think of all those senses perhaps being all hyperactive or hypoactive, so you can't sense them as much, and in adolescence they might fluctuate to be hyper and hypo. You've got a lot of sensory stuff going on. So to try and think about how to make the bedroom work for that individual. Let me give you an example. So one gentleman I worked with, his sense of where his body parts were was lacking. So when he goes to sleep, when his eyes are closed, he doesn't know where his feet are, and he found that quite frightening. So it didn't help him stay asleep. So what we did was make him have an end of bed board as well as a headboard. And so he propped his feet up against the end board, and then he knew where his feet was because he actually got a sense of where they are from the skin. So it might be a whole load of other things as well as cognitive behavior therapy that we might need to incorporate for the individual.
And I wanted to ask, kind of along the lines of cognitive behavioral therapy, if there's anything unique in neurodivergent patients that you've noticed about how you need to modify cognitive behavioral therapy. The reason I'm bringing that up is because I actually have a case of a gentleman that I'm helping now. And it's interesting because, and I do a very thorough intake. He never mentioned this question of autism spectrum, but I noticed in his mannerisms, in some of the issues that he's working through in a group home environment, he has a very strict kind of routine, and he has a really hard time being able to kind of sleep restrict. And any little thing, the simplest thing, could seem very overwhelming to him. Whereas for you and I, it would just be another day. Oh, that store didn't have X, Y, or Z. I just go to a different store and, well, I got what I needed. Well, that could throw him for a loop for a while. That's been one of the most difficult things, is one of the key components. It's just a component, but one of the key components in cognitive behavioral therapy is actually restricting time in bed. And because he's very good with being almost ritualistic about his bedtime routine, it almost works against him because we've had a hard time in his mind. He has this horrible insomnia. In my mind, I'm like, well, you're spending an awful lot of time in bed. And if we narrowed that down, I think we could really improve you. But being able to get him to be comfortable with that has been a very slow and incremental process. Have you found the same? Are there any unique things that you've had to deal with?
Absolutely, Alison. It's very, very common. And, there are 6 elements to cognitive behavior for insomnia. So I very often don't start with sleep restriction. With the general population, clinicians will say to you, oh, sleep restriction is the best. Let's do that first because we get some wins, and then we can put some of the other things in place to scaffold it a little bit more. For people with neurodivergency and some other health conditions and disorders that might not benefit from doing it that way around, I wouldn't go always first for sleep restriction. I would actually think about sleep hygiene or stimulus control. I would also be thinking about that circadian rhythm. So when people have got insomnia, they get quite obsessed with their sleep. And actually what I like to do is not to do a sleep diary, but to do a day and night diary. So we can get them to stop obsessing about the sleep, but thinking about what they can do during the day that can benefit their sleep. So that their over focus is reduced, which actually calms them down to some degree as well. But also on top of that, people with autism particularly, I don't know enough about ADHD. I haven't found it with the clients in my clinic, but definitely people with autism, often they perceive they're awake when they are actually asleep. So and I think there might be, and there's no literature yet about it, but it seems quite common that when people are in that REM sleep, of course, it's quite close to wakefulness. And if you think that people with autism have a heightened, a hypersense of their senses, maybe it's their sense of sleep as well is being heightened. So getting them to trust when they've had a night study that actually they are asleep, although they don't feel it, and going off what dreams they've had and having a conversation about deep sleep being important as well as a REM sleep, so they don't get overly focused on REM sleep, and just explaining to them, you're not going to get REM sleep in great quantities till halfway through the night and into the morning, and that you're getting the good physical recovery at the start of the day can actually be hugely beneficial, and they don't end up becoming super focused on why is it I can't sleep in the morning, and actually, perhaps I'm sleeping, and maybe it's a dream that I'm having rather than thoughts that I'm having. So that it's going to be an interesting way forward, I think, as time goes on, because there's going to start to be some research on this.
Yeah. So for those who are listening, what Jill is referring to is something that we call sleep state misperception, or it's essentially this. Typically, it's been hard to describe other than to just generally refer to it as you are basically asleep, but you think you're awake. Often what I've seen on polysomnogram, when I've taken a look at folks that have polysomnograms and we find this, is that they may actually have more lighter sleep that they're perceiving as they're awake. But I find it interesting because you are commenting that what you're seeing in the neurodivergent population is they may, especially autism, they may kind of tend to see the second half of the night, which is what you mean by we have more rapid eye movement sleep at the second half of the night. So our sleep architecture, which is non-rapid eye movement sleep and rapid eye movement sleep, we tend to have more deep sleep in the beginning of the evening and more REM sleep toward the end. And REM, even though our minds are just as active as awake, the way we know we're in REM is we actually see that there's no muscle tone. We have a loss of muscle tone. But because your minds are very awake, and if I woke you up in REM, you'd actually feel quite awake, there can be a lot of dreaming that's not necessarily what's happening in reality, but it can get a little confusing for some folks. So I've never heard it described as that. And I find that particularly interesting, that REM sleep part of it, because I would be very curious. I honestly did not do my homework, guys, as much as I usually do. They know I always try to bring up studies and everything. But I don't know if there's a ton of polysomnographic data. I have not, when I reviewed the literature several months ago, did not see a whole lot in terms of like how your sleep architecture specifically changes if you're autistic. But I think that that's a really unique perspective, and also one that just shows the power of observation, because it kind of makes logical sense if they are sort of hypervigilant to other things.
Yeah. And therefore, and I think that's going to be the hardest, because even if you had polysomnographs, it's their perception, not the actual data that you're still talking about. So I'm not even sure if some of that research would be helpful. We have to trust people with autism to tell us how they feel is the most important thing. But I also think that our language doesn't help us. When people talk about being tired compared to fatigued, they mix them all together all the time, don't they? So they may feel fatigued. Like you said, if you wake up in the middle of a dream, you might feel more alert. But, if you wake up in a deep sleep, then you're not going to be feel more fatigued. But knowing that tiredness and sleepiness, that grogginess of your eyes closing and not being able to get your head off the desk feeling, or you're falling asleep and watching the telly, that's a different kind of sleepiness to fatigue. And helping somebody with autism to know the difference between those, to begin to be more self-aware about how many hours they need for sleep. Because also we have this ordinary average idea that we should all have 8 hours sleep, whereas actually we're all individuals, and people with autism may need more sleep because they have such sensory overload with what's happening around them, as well as trying to deal with social communication and the relationships that they might be struggling to work their way through. There's a lot more cognitive overload, and therefore quite often people with autism and people with learning disabilities actually need more sleep. It's not uncommon for them to need 9 hours sleep just because they need more time to process what's happened in the day. So actually asking somebody, how many hours sleep do you need to feel rested, is the most important question to ask. And then trying to work out how much time sleep, are you going to try and help them get to be able to do that, whether they perceive it as sleep or whether they perceive it as just resting. How rested do they feel? How much more energized do they feel after they've got maybe 9 hours instead of the 7, 8 hours that they thought was the norm, but not their norm?
So what I'm hearing from you is, in reality, what we need to do is start shifting our neurodivergent loved ones and people in our lives to thinking about them really as being elite athletes, but not in the physical sense, because I've spoken with a ton of elite athletes now at this point, and all of them say universally, like, sleep is super important, and how much sleep can you get? And often it's in the 9 to 10 hour range.
Yeah.
Sherry Ma's done a lot of research about this over at Stanford. When you think about that, this is you're mentally elite. You are constantly burning and churning in that head of yours. And there's a lot of cognitive overload. And I didn't think about it, but when any of us are feeling really stressed, overwhelmed, it may look different for someone whose stresses or overwhelm are more in the classical, typical sense. But nonetheless, it's exhausting. I know that's how I felt during COVID when I was I just felt every day when I came home from an ICU shift, I was cognitively overloaded. And it was so hard to kind of work your way down from that. And then to have insomnia on top of all that. So then you're like, okay, now I'm sleep deprived. Now I really can't handle it. And it's not getting better. I can only imagine the struggles of some of the folks that you are trying to help over there in the UK.
Yeah, over here in the UK and America, all over the world, that have got exactly the same problem. And then on top of that, people with insomnia can also develop sleep apnea. So they can suffer from COMISA, which means that they're not breathing well. So actually, some of the techniques to help relax somebody so that they can get back off to sleep or start their sleep or start the onset of the sleep can be really useful for during the day. So I will teach breath techniques. Learning how to just breathe through your nose and not through your mouth can have an impact on the sleep apnea, as well as your polyvagal nerve, making sure you're not in the fight and flight mode, you're in the rest and digest mode. By using your breathing, it's a powerful mechanism, but it has a physiological mechanism that can be useful for your sleep as well, if that makes sense.
I think what I'm hearing from you really is that a lot of the techniques that we use in a quote neurotypical person, they may be even more powerful and more important to emphasize in a neurodivergent person, but ultimately it's universal. We all need to sleep. We all kind of have the same sleep issues. It just looks a little different.
Yes, absolutely. And definitely those CBTI techniques work in exactly the same way. We just might need to emphasize the element that's called relaxation or mindfulness. We have to just drill down in a little bit more detail. And we might need to be, like you said, be really good at assessing right at the beginning to make sure we haven't missed any sleep apnea that might be there alongside insomnia, because there's no point solving only half the problem. If somebody's still got sleep apnea, then that's not going to be useful to them. And often it can be the case that somebody with autism and ADHD is living on their own and they haven't got anybody else that can tell them that they're snoring or that they're gasping for air. So you might have to say, when you go and spend time with your family, or when you're on the train, or do you notice it yourself? Do you wake yourself up? All those extra questions. And then if that doesn't work, I might even just send them to get the test done, because we're better off knowing and ruling it out.
Yes. Thank you for saying that, because it's one of the things that it boggles my mind that we don't, Stopping doesn't mention anything about insomnia. Some of the really common tools that we use to assess for sleep apnea or assess risk for sleep apnea kind of miss a key link, which is, do you have trouble with your sleep? And that often, especially for the ladies and for folks who are neurodivergent, the bottom line is that that's often a very big complaint. It's not going to be the other stuff. Jill, this has been such a hugely important conversation, and I'm really happy that you're willing to give me your time to talk about this. I want to reiterate to everyone before we sign off here that she offers 15 minutes free consultation on the phone. She holds a virtual clinic on Tuesday to Thursday, and she also runs wellness workshops that focus on sleep. Go to her website, www.sleepbetterdoctor.com. And Jill, did you have any final words before we sign off today?
Yeah, I always like to finish on make sure that you have nailed your sleep hygiene. And I don't mean sleep hygiene in like the 110 tips. I mean, I always describe it as 4 things. Get the heat right, get the light right, get your nutrients right, and get your routine bottomed. So I could go into the detail of those 4, but sleep hygiene is the same as dental hygiene and hand hygiene. Even when you're poorly and it's not working, your teeth aren't working properly, you need root canal treatment, you still don't forget to brush your teeth. It's the same with your sleep. You're not going to have good sleep without good sleep hygiene.
Thank you so much. This has been so fun.
Yeah, it's been great. Really loved it.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.